Hello, everyone. I'm Emily Khazan, Vice President of AtlanticLIVE, and I'm delighted to welcome you to Pulse, our annual healthcare event. We have so many expert viewers from across the country and indeed even the world. Nurses and doctors, scientists, students and teachers, members of the media, and more. We have a day of programming ahead of us, and I hope you'll stay with us for as much of it as you can. You can find our full schedule at pulsehealthcare.theatlantic.com. For the next half hour or so, we're going to talk about the new doctor's office. The pandemic has forced many hospitals and clinics to rethink the way they care for patients. From telehealth to full-scale redesign, now is the time to experiment on what healthcare should look like. We'll hear from a few industry leaders on their perspective on this. I first want to thank our underwriter, Pfizer, for their support of today's event. And I'm delighted to introduce Mike Gladstone, Global President of Internal Medicine at Pfizer, to provide us with a few framing remarks. Mike?
Well, thanks, Emily, and thank you all. I'm excited to be here. So I visited my in-laws a couple of weeks ago, and my 84-year-old father-in-law leaves the room and says, I have to go to the eye doctor. And we're like, what are you talking about? You're going nowhere. We blocked the whole driveway. He goes, no, the eye doctor, my iPhone. And we all started laughing because this is a guy who could not text 6 months before COVID hit. But it really gives you an idea about what has changed since, and the magnitude that has changed since COVID times. The new doctor's office is here to stay. The new doctor's office, we call it telehealth, so, oftentimes, but essentially, what is it? It's managing healthcare via electronic media, voice, text, audio, AI, but all this has been accelerated big time by COVID. My father-in-law is a great example. Another example, one large US healthcare system used to have in 2019, 4,000 visits for telemedicine for the entire year. Every day they're having 4,000 visits via telemedicine. And this is not a one-off, this is the norm. Telemedicine is a force. And I think it's a force particularly in 3 areas. And I think one of the most interesting of those areas is it can help provide equity in healthcare. Equity is one of Pfizer's core values, and a lot about that is reducing healthcare disparities. Telehealth can play a role here. What would that role be? When you think about access to medicine in some rural communities, it's not very good. And even access to broadband in some cases is not good. But now these individuals, it's becoming more mainstream. They can have visits on the telephone. They can do them when they have bandwidth through the phone. Secondly, this new doctor's office is an area of empowerment for patients and physicians. Remote monitoring is becoming more commonplace now. Digital stethoscopes, thermometers, asthma inhalers, everything is growing exponentially during these times, especially for monitoring chronic conditions. The third way that I think telemedicine, the new doctor's office, can be a force is with partnerships. At Pfizer, we've entered into partnerships that a few years ago we never dreamed possible. One of the areas of focus for us is to help patients with atrial fibrillation get diagnosed because it's a major cause of stroke. My father found out about his AFib by accident. He was doing a surgical procedure. And thankfully he's treated and we're very glad that he's healthy. Many patients don't have that luxury. So wearing Fitbits, monitors, you can actually detect atrial fibrillation. We've entered into partnership with Fitbit. We're seeing a lot of those sort of partnerships that we never dreamed of before. So the bottom line is a good side effect of this pandemic is that barriers have come down. Partnerships are coming together that we never dreamed possible. And it's all revolving around the new technology that we call the new doctor's office. And so with that, Emily, I'll kick it back over to you.
Thank you, Mike, and thanks again to Pfizer. A quick reminder that you can be a part of the conversation by submitting your questions through the Q&A feature on the bottom of your screen. Keep your questions short and on topic, and let us know where you are watching from. And with that, I'd like to turn things over to Atlantic staff writer Olga Khazan to lead our discussion. And Olga is joined as well by Andrew Diamond, the Chief Medical Officer of OneMedical, and Tim Wong, the founder of iHealth Clinic.
Thanks so much, Emily, and thank you, Tim and Andrew, for being here. I wanted to start with you, Tim. You opened up iHealth before the pandemic started because you were disillusioned with the way that healthcare works normally. I was wondering if you could kind of tell us about iHealth and kind of how it's different from other doctors' offices that people might be familiar with.
Sure. I've never seen other providers do the exact same model, so I think it's pretty unique as far as I can tell. It kind of pairs direct primary care, but also with a micro practice. Um, th that might not be clear, but what it is a medical clinic. We do urgent care, primary care. We don't work with insurances, but also I'm the only staff member. And because I'm the only staff member in the micro practice, we can keep costs low. We don't charge memberships, and most of the visits are actually just $35.
How do you do that? Because that $35 figure is pretty striking to me. How does it actually work to charge someone $35 for a doctor's visit? Which, like, when I go to the doctor, for example, and I see the bill on my health insurance before the insurance kicks in, it's usually like over 100 at least.
Sure. So it was kind of designed from the ground up to be super efficient. And so we decreased the second highest cause of a medical office, which is support staff. So as the only staff member, the cost is quite low compared to an average or traditional office.
So what happens if someone doesn't have $35 but needs to see you?
So a lot of people do know that it isn't a free clinic, but I've had a few, especially during the pandemic, who didn't have it, and that's fine. I just don't charge them.
Oh, wow. Okay. Well, Andrew, I wanted to kick it over to you because OneMedical is a little bit more established. It has more branches. We have it in DC, for example. For people who aren't familiar with it, can you describe the idea behind OneMedical and sort of how it's different from a normal doctor's office?
Yeah, well, thanks so much for having me here, and to everybody across the globe who are participating here. And it's great to be able to get together and share some of these thoughts, and to meet Tim and others. One Medical started in 2006, 2007, really from some of the same motivators: disillusionment with the state of healthcare, the state of technology in healthcare, particularly the state of primary care for the people who both deliver it and the people who receive it. Just not great experiences, terrible wait times, terrible access. And so we set out to change all of that. This was a time when the micro practice model that Tim just described was starting to come into its own, and we were in many ways a micro practice like clinic, just a couple of doctors and minimal support staff. The whole idea being very similarly to take out a lot of the inefficiencies and wastes. But the other important idea for OneMedical was to start to achieve some scale. So as we have grown, and from places where we originated here in San Francisco, but now we're in DC and 12 other major metropolitan areas across the United States, we're able to scale our technology and scale a lot of our other systems to be able to deliver really high quality, high touch care to a lot more people, a lot more efficiently and effectively. And the idea is that it's a membership-based model, and we do work with insurance, which is a little bit different from the direct primary care model that Tim described. But a lot of technology and a lot of team-based care.
And how much is the membership, and what does the membership offer you?
Well, the membership is on average $199 a year, so somewhere in the neighborhood of $16 a month. With the membership, you're getting access to all of our technology, including 24/7, 365 virtual care for questions that may pop up, things you need somebody to help you with in the middle of the night, prescriptions you might need called in, all of our other technology-based services.
Hmm. So I wanted to ask, I mean, obviously we've had a huge shakeup in all parts of life, but including medical care. How has COVID affected your practices? What has been different about it during the pandemic? And let's start with you, Tim.
I've seen huge drops in actually volume and revenue. I think primary care, urgent care clinics, and even ERs have seen the same thing. I think, you know, if you look at the news, it's about 40 to 70% at its peak in about April. So it's pretty tough. I kind of, for a month, actually reduced the $35 fee to even lower, just because a lot of our patients are actually in the service industry. So we're really, really hit by the pandemic.
Right. And what about you, Andrew?
Well, it's been really, really interesting to see how our practice has reacted. I think I would characterize our response in three main areas. One was, especially in the very early days, recognizing that as the in-person visits go away, because people have to stay home, there's shelter-in-place orders in all of the cities where we operate, put into place, you know, over the course of March and April. We had to shift a lot of our care to the virtual world. And we feel very fortunate to have already had an app that supported that kind of care. And we were able to work with our own in-house technology team to add new features, such as being able to schedule appointments for that type of virtual care on top of the sort of on-demand virtual care that we were already doing. So we had a huge amount of our visits shift over to the type of virtual care that Mike was describing earlier. We also recognized that not 100% of the care that we need to deliver is going to be deliverable virtually. There are certain things you have to do in person, and over time, the need for those in-person visits is just going to keep accumulating. So we had to emphasize making our offices as safe as they could possibly be for our staff and for our members. So we put a lot of energy into that. And then lastly, we recognized that there continues to be an enormous need for testing. So we also began offering COVID testing services, and we created outdoor testing facilities that are sort of high throughput, where people can drive through or walk through to get tested. And we've been doing an enormous amount of that, tens of thousands of tests for our members across the country, and for many brand new members, where we're offering the opportunity to join OneMedical sort of on a provisional basis to get tested.
And how does that work to diagnose someone virtually? Like, it seems great. Like, I would like to do that in normal times, but what are some of the challenges associated with doing kind of eye medicine, and how have you overcome them?
I think actually in at least primary care, there's actually this shift away from the physical exam in a lot of cases. Certain things, you know, you really don't need a physical exam, you know, the majority of chronic illnesses. So it was interesting because there's a lot of literature about how the physical exam is changing. And I think telehealth is really kind of one of the battlegrounds of seeing that.
What do you mean the physical exam? Like, give an example of that. Cause like when I think about, you know, oh, I have a weird rash, I feel like the doctor needs to physically look at it, right? Or are you talking about other types of illnesses?
Sure. So the physical exam incorporates everything from, you know, kind of gauging the person's mental status just from a text conversation without images or videos. Like you pointed out, the physical exam can also involve inspection of a picture of a rash as well.
Andrew, how do people how do your providers balance the constant, you know, if someone wakes up in the middle of the night with a stomach ache and they want to reach out to their OneMedical doctor, do your doctors just not sleep? Do they have like their iPhones like under their pillows? Like, how do you actually manage a 24/7 virtual workforce?
Well, I mean, that's a great question, and it's why team-based care is just so critical. We know that what happens when you have a really great relationship with an individual primary care provider, the level of care that you get is really unparalleled. But that primary care provider can only be available so much, and we want everybody to have healthy, well-balanced lives. So we need a team of folks that are supporting one another and supporting those primary care providers. So at OneMedical, we have a virtual medical team that is just staffing our virtual care channels around the clock. And because we're all sort of using the same electronic health record and all part of the same organization, it feels like very seamless care for our members. But we're only going to wake up the primary care provider in the middle of the night if there's a really particular need to do so.
I feel like the question that this is, and Tim, I know you don't work with insurance, but Andrew, for insurance, how does this all work? Because like the thing that I've always heard that's the hurdle to implementing something like this is, well, we don't get paid for text messages. We don't get paid for phone calls. So we're not going to do them. So you're going to come into the office. We're going to bill the visit. How do you deal with all of those logistical hurdles with insurance?
Well, pre-COVID, we dealt with it by bundling that sort of as part of our membership. So when you're a member of OneMedical, you get access to those types of services that are not typically covered by insurance. To the extent that COVID has helped drive some changes in reimbursement for virtual care, we're able to participate in that. But it's pretty hazy. Nobody knows exactly where this is headed and whether or not the reimbursement will really be sufficient for many medical practices to continue offering a lot of virtual care down the line. So it's an area where we just need to be able to respond very quickly to changes in the reimbursement model.
And to be clear, you charge a copay on top of the membership, right? Is that?
If a patient's coming in for an appointed visit, whether it's virtual or in person, if you're having an appointment with a doctor rather than an on-demand type of visit, then that will be billed to insurance and there'll be a copay if you have a type of insurance that involves copays.
I see. Tim, I want to drill further into this $30 doctor idea. How does it work? Like, what if the person comes in and they just have like a bunch of problems? Like they have a lot of healthcare needs. They have like skin issues and stomach issues and diabetes, and they also aren't feeling well mentally, and they want help, quitting smoking. And you end up having to talk to them for like 30 minutes just to get their history and all the doctors they've seen and everything they've tried, and it's taking forever. Do you still just charge them $30? And if so, do you feel like that's sustainable?
So actually, when I designed the clinic and the pricing model, it was actually kind of based on the free market. And one of the principles is if you're going to consume more as a consumer, like you pointed out, if you're someone who needs help in one visit with multiple issues, the free market says you pay more. So if you go to a sandwich shop and you buy kind of one sandwich, you pay a price, but two sandwiches, everyone will tell you is probably more than the one sandwich. So we do add per problem. And I think that's actually very important in healthcare because there's no barrier between kind of treatment and the cost. And often that's why there's a really high cost in healthcare, because we never see that bill until after the fact. But when you know kind of the cost straight up, sometimes you can prioritize a little differently.
Wait, so I guess like that, but then someone could come in and like, do they have to basically, if they have limited funds, do they basically have to triage their problems? Like I can only afford to talk to you about my left leg, but not my right leg. I don't know.
In some ways, I would say the person who comes in with 5-6 different issues, generally, I don't see them too often. Usually it's, we follow Occam's razor in medicine. One problem actually manifests as multiple symptoms rather than multiple problems causing multiple symptoms. And it does play true every day. And so actually a lot of people have multiple symptoms, but it's actually really just one issue.
Right, I see. This is a question for either of you. What's the hurdle to more, I guess, doctor's offices doing something similar? Like I'll admit I don't have a primary care. I just go to urgent care because I feel like I literally never have gotten sick between 9 and 5 on a work day. Like it always happens on a weekend or at night. So I'm always like, why isn't every place just an urgent care or something similar? What are some of the hurdles of doing more of this?
I think one of the major issues that you point out is on primary care side, there is a huge kind of archaic system where, we do kind of require instant access now. With Amazon Prime, same day shipping, it's kind of the expectation. So primary care is lagging, and actually a lot of studies show that a lot of patients don't actually have a PCP for the exact same reason you pointed out. But the big difference in urgent care is if you come in with a headache, I'll treat your headache. That would be the urgent care aspect. But I'll also ask, hey, by the way, how often are you getting these headaches? Oh, you're getting them 6 times a month. Well, we need to put you on a medication daily to prevent that headache. So you're actually also fixing the chronic issue and the underlying problem.
Yeah.
What helps so much, I couldn't agree more with everything Tim's saying, the value of having that primary care provider to help deal with prevention and sort of the big picture, and to be part of a system where you're actually also going to get the follow-up call, the follow-up email, the follow-up outreach in some form to see whether or not that new treatment is working. Did the acute treatment work? Did the preventive treatment work? Hey, now it's time for this cancer screening. All of that's possible when you're dealing with kind of a forward-thinking model. But to the question of why more folks aren't doing this, I think there are important hurdles, both in terms of the operations of a typical practice. I mean, just being able to guarantee access, because people do want that Amazon Prime-like experience. A staffing model that supports that kind of access requires sort of breaking some eggs, so to speak. You have to get used to doing things very differently from the way you might have been doing them for many, many years. And then you also need technology in many cases to support it. Although it could be as simple as using FaceTime, but in many cases, to really have an electronic health record that's working across the entire ecosystem, that's a big hurdle for a lot of folks.
Right. We actually have a question from an audience member, Sarah. How can we make team-based care accessible for people who cannot afford a membership fee, like patients on Medicaid or Medicare, or who otherwise cannot afford it? I guess I could throw it out to either of you.
Well, this is something we've been thinking about a lot recently, but certainly since our very earliest days at OneMedical, trying to make this care model more and more accessible. It does begin with making sure that the cost of the care that we deliver can be as low as possible by delivering it as efficiently as we can. Back to where Tim started, stripping out a lot of the inefficiencies that exist typically in healthcare. But it is a really, really big challenge to get it so efficient that you can operate at the kinds of reimbursement that Medicaid, for example, is offering. So we believe at OneMedical, at least, that our membership fee is already very, very affordable. For those who demonstrate financial hardship, we are happy to waive that. But we also need to work on improving reimbursement. So ideally, in the wake of especially what we're seeing with the COVID pandemic, we will hopefully see bigger investment in reimbursement for these safety net types of policies, or better ways of bringing more Americans into these safety net programs and helping primary care providers actually get paid fairly to deliver that care. And then lastly, there's always the possibility of subsidizing the care for those patients with revenue generated by caring for other patients. And that's something that we are ideally going to be able to do at OneMedical and through many models across the country.
There's also a lot of clinics around the country called federally qualified health centers, which do have a team approach. And so a lot of patients do have access to that. And they do have a sliding scale as well. So that could be a resource. I think an underused resource as well is actually primary care residencies. A lot of training for doctors actually have clinics so that they can learn and have their own patients. But these clinics also have extra resources like a social worker that can really have that team approach that you might be wanting.
Yeah. There's another question from an audience member, Tiffany. Are there particular federal or state policies that can support businesses like OneMedical in providing sophisticated team-based care to more people?
Well, we're certainly seeing a lot of things happening in the virtual care world. I think some of the policies that we are hoping to see that would be more impactful would be, number one, making it easier to care for patients across state lines. some of the more savvy audience members may understand that in order for a provider in California to care for a patient in Texas, you need to have a license in Texas. And so there are, there's a growing list of physicians and other types of providers who have gone to the trouble of maintaining medical licenses in all 50 states, but that is extraordinarily expensive and time consuming and doesn't really bring any clinical benefit. So right when COVID started, the federal government helped ease some of the laws that were restricting that type of cross-state medical practice, but we'd like to see more of that become just the laws of the state. We recognize that there's some major hurdles to changing the way all of these states do business when it comes to medical licensure, but that would be a great thing to see. The other thing, back to one of your earlier questions, that we would love to see would be just making all primary care services pre-deductible so that nobody has to think to themselves, should I seek care for this? I don't want to pay a copay for my right knee when I already had a visit for my left knee. Or I've already maxed out my what I can afford to spend on healthcare this year. I better just ignore this headache. And that's really a terrible way for people to think about primary care. It might be a good way to think about whether or not you get an elective surgery, but primary care we don't think of as something that really should be elective. If you've got a problem that you want to discuss with a primary care provider, you should be able to do that and have that be fully covered by your insurance. So that's another area in which we're working with folks in Washington to try to drive some change.
Anything to add to that, Tim?
Yeah, there's actually not too many regulations that prevent a provider to create their own clinic, which is surprising. But I think this, as Dr. Diamond said, that the state regulations do make a huge barrier. And I'm in Pittsburgh, right near Ohio and West Virginia, so it can be a little tricky there.
Yeah. We're going to have to do a lightning round because we're running out of time here, but a quick question from someone who's thinking about setting up their own telehealth practice instead of retiring. Any quick word of advice that you would give on setting up a good EHR and figuring out the billing through insurance?
Actually, looking at various vendors, it's pretty important. Eventually, after you see 3 vendors, you kind of get a feel of really the differences. So, online, there's tons of vendors, and telemedicine is, there's probably like over 100 platforms for sure.
Yeah, the only thing I would add there is there are certainly a lot of vendors to choose from. There are a lot of companies that are hiring folks to do just telemedicine. The one word of caution that I have been thinking about is that as fantastic as telemedicine is, it doesn't replace really 100% of what you kind of go into medicine to do and what you really love the most about it. While on the one hand, suddenly you're getting a look into people's lives that you may never have had by being able to see inside their homes and see who they live with, et cetera. And that's absolutely amazing. It's like making a virtual house call with each appointment. So that's fantastic. But on the other hand, not being able to just put a hand on a shoulder, listen sort of directly to somebody's heart, or look right into their eyes and have a difficult conversation about a heavy topic. That all, there's something that is magical about doing that in person that telemedicine doesn't really fully capture. So just a quick word of caution on that.
Well said. Well, thank you both so much. This is a very fascinating topic, and I will toss it back to you, Emily.
Thank you so much, Olga, and thank you again to Dr. Wong and Dr. Diamond, and thanks to all of you for watching virtually. We will take a break now and see you in half an hour for another special session on how cities can achieve health equity for all. See you then.